What's the mechanism of arrhythmogenesis? How is an arrhythmia produced? So there are two mechanisms. There is enhanced automaticity and re-entry. What are the basic properties of the cardiac muscles? What's the properties of cardiac tissue? Automaticity, rhythmicity. These are two basic properties. So you can have this enhanced or decreased automaticity. There is re-entry or there is blocks in the conduction. So which can produce various type of arrhythmias. You can have tachyarrhythmias, you can have bradyarrhythmias. Now, decreased automaticity, it results in bradycardia. What are the conditions which you can see you have decreased automaticity? You see, this is a classical example of bradycardia. What type of bradycardia is this? Jay? It's a sinus bradycardia because you can see a normally configured P wave. So the complex is complete PQRST. So this is sinus bradycardia. What are the conditions you see sinus bradycardia in? Which conditions you see sinus bradycardias? Yes? So it can be in athletes, well-trained athletes. They can even have first-degree heart block. And not old age. That is not sinus bradycardia. Generally, they develop, we'll see in the block 6 sinus syndrome. Hypothyroids, hypothermics, patients who've got beta blockers or other drugs which can slow down the heart rate. So it may be during deep sleep. So increased automaticity, you can have different type of tachyarrhythms. Supraventricular rhythms, there may be ventricular rhythm. Ventricular rhythms are usually, they can be because of both automaticity or there may be re-entry phenomena. It can be both. Now what is this first picture? This is sinus tachycardia. You see all the components. What do you see here? This is ectopic atrial tachycardia. Now, what will be the difference between atrial tachycardia and the sinus tachycardia? How do you identify this is sinus tachycardia, this is atrial tachycardia? In sinus tachycardia, the impulse is coming from the SA node to the AV node and then down below. While in atrial tachycardia, it's coming from the atrial tissue, not from the SA node. So what will happen? The P wave will be having a different morphology if you compare it with the previous ECGs of the patient, and the PR interval will tend to become smaller. And then you got the third picture, which has junctional tachycardia. What is junctional tachycardia? It is coming from the AV node. If the patient has tachycardia that's coming from the AV node, it's called junctional tachycardia. Now, what are the features of junctional tachycardia? So the P wave will not be there. Why the P wave will not be there? Because the SA node will be producing a current. It's not the SA node is dead. So SA node is also producing a current. So why won't you have that P wave? So this will be embedded in the QRS complex. It will not be easy to dig it out. So you don't find a P wave here, and you've got a tachycardia. It's a narrow complex tachycardia. The complexes are narrow. Now, the re-entry tachycardias. What's the mechanism of re-entry? Can anybody tell me what's the mechanism of re-entry? But how the alternate conduction results in re-entry? Let's call the circus movements. Good, the start is right.
One is the fast conduction pathway.
So there are two conduction pathways. If the heart has abnormalities and there is an additional conduction pathway, one pathway may be fast pathway, the other may be slow pathway. Beta pathway, fast conduction, long refractive period, slow conduction, short refractive period. What happens next?
So the fast conduction pathway has a shorter repolarization phase, and the slower conduction pathways are.
So how would the arrhythmia be generated?
Sorry?
Arrhythmia कैसे generate होगा?
So retrograde transmission through the pathway.
So when a normal impulse comes from here, it will be traveling quicker here and it will be traveling slowly from here. But when it reaches here, this is in refractive period.
Yes.
Okay? It has a longer refractive period. So it will be blocked here. So this impulse will be conducted downwards. So this is going to produce a normal beat. But if there is an abnormal beat which starts, so suppose if an abnormal beat falls in here or here, when this is conducted around that loop, it may find that one of the pathway is not in refractory period and it enters into that pathway. So that results in a circular movement. So this produces the re-entry tachycardias. So these are re-entrant tachycardias. AV nodal re-entrant tachycardia, AV re-entrant tachycardia, which is orthodromic or antidromic. Orthodromic का मतलब क्या होता है? What's that? It's going downhill. Antidromic, it's coming back into the atrium. Atrial flutter, fibrillation, and ventricular tachycardia. Now, what is this arrhythmia? This is AVNRT, atrioventricular reentrant tachycardia. Now, this is an interesting thing, multifocal atrial tachycardia. What is this? So this would be because of the enhanced automaticity, or this will be because of the re-entry? This will be because of the multiple areas of automaticity, because they are firing from different places. Now, how can you identify this multifocal atrial tachycardia, or it's called MAT? And this is important. This has to be differentiated from another similar rhythm in which there are no P waves, that is atrial fibrillation. So how would you identify this multifocal atrial tachycardia? What do you see in this? The rhythm is quite variable. Rhythm, you can see the rhythm is quite variable. So is the P wave. You see the P waves are different because they are coming from different foci, so they will be having a different morphology. So the P waves have different morphologies. The PR interval is varies, the RR interval also varies. So this is multifocal atrial tachycardia. Discrete P waves with at least 3 different morphologies, atrial rate greater than 100 beats per minute, and all the PP interval, the PR interval, the RR interval, they all vary. This is an irregular rhythm. And when you see on pulse, the other irregular rhythm, which is atrial fibrillation. So when you see on pulse that is irregular rhythm, you have to differentiate primarily between these two, the MAT and the atrial fibrillation. Now, what is this rhythm? This is, you should identify this. What is this? This is ventricular tachycardia. Good. This is one of the very serious rhythm disturbances. This is ventricular tachycardia. And then you can have different patterns of ventricular tachycardia, the single beats, maybe atrial contraction, this may be junctional beat or PVC, and this can come in couplets and triplets as well. So this is an example of a couplet. This is ventricular bigeminy. These are usually benign conditions. Now, pre-excitation, when there is an accessory pathway, this is called WPW and LGL. What's the difference between WPW and Langerhans-Levine syndrome, LGL? There is an accessory pathway which connects the SA node to the ventricle or to the AV node. What are the normal pathways which connect the SA node to the AV node? Are there any atrial pathway, specific atrial pathway which connect the SA node to AV node? It's Wenke-Bach, Bachmann, and Thorel. All the same? These are the 3 pathways which connect the SA node with the AV node. And then down below, you've got bundle of his and its branches. So what's the characteristic of this excessive pathway? It's called pre-excitation. The PR interval is usually short. It's less than 3 small squares. If it's only short PR interval and there is nothing else, it is called LGL, Langerhans-Levine syndrome. You should know this. Why have we placed this pre-excitation syndrome here? Why it needs to be discussed in these arrhythmias? Because it can be a problem. It produces a broader QRS complex. There is a delta wave here. So it causes a broad QRS complex. And if there is a tachycardia with this supraventricular tachycardia with this condition, it may look like a broad complex tachycardia. And the broad complex tachycardia generally is ventricular tachycardia. What else condition can cause a broad QRS complex tachycardia, which is a supraventricular tachycardia, basically, not ventricular tachycardia. Ventricular tachycardia is a broad complex tachycardia. Supraventricular tachycardia is a narrow complex tachycardia, except if patient has pre-excitation like WPW. And what's the next condition which can produce a broad complex supraventricular tachycardia? One is SVT with aberrant conduction. The other one is SVT with bundle branch blocks. It's either left bundle branch block or a right bundle branch block. That can produce a broad complex tachycardia. So you have to differentiate these two conditions. Treatment is slightly different. And ventricular tachycardia is more serious. ECG of WPW, short PR interval, QRS prolongation, a delta wave in the upstroke. Now, how would you differentiate ventricular tachycardia from supraventricular tachycardia? This is an important thing to remember. If you've got a broad complex tachycardia, if it's a narrow complex tachycardia, it's easy, this is supraventricular tachycardia. But if it's a broad complex tachycardia, you have to decide is ventricular tachycardia or supraventricular tachycardia with broad complexes, that is WPW or bundle branch blocks. How would you differentiate these two? Yes? What is? Supraventricular tachycardia may contain a P wave, may not contain a P wave. For example, if it is arising from the node, it may not be showing a P wave. Node means AV node. When you call nodal tachycardia, it's AV nodal tachycardia. Whenever it's coming from the sinus node, it's called sinus tachycardia or like that. So if you read a term nodal, it means it's coming from the AV node. It's not sometimes 100% possible to differentiate on ECG between these two rhythms, but there are certain criteria. Using those criteria, there's very strong probability that you can differentiate between these two. All broad complex tachycardia are to be taken as ventricular tachycardia if you cannot decide this is supraventricular or ventricular. So any broad complex tachycardia, if it is present, if you are confused, this is to be treated as ventricular tachycardia. Ventricular tachycardias, what is this? Far more serious. So we remember this ABC. If the axis is northwest, what is northwest? Extreme right axis deviation or indeterminate axis we saw on the upper left side of the circle we saw in the session on how to see axis. So it means the AVR will be positive. If the AVR is positive, the likelihood of this being ventricular tachycardia is more. SVTs don't have this sort of thing. Breadth of QRS complex, if it is greater than 200 milliseconds, if it's greater than one large square, this is a very strong case of ventricular tachycardia. In bundle branch blocks, usually it's not that broad complex. Concordance. What is concordance? In the chest leads, either the QRS are upward or they are all downward. Okay? from V1 to V6. Concordance means they are either all of them are upward or all of them are downward. If there is concordance, is a very, very strong case with almost 97% specificity for this being a ventricular tachycardia. If you find complexes, some of the complexes are upward, the other ones are downward, this is not a strong case for ventricular tachycardia. So if there is concordance, this is ventricular tachycardia. Dissociation. Dissociations mean AV dissociation if it is present. You find P waves and QRS complexes not related to each other. In supraventricular tachycardia, they will be related to each other. But if there is a dissociation, we have a different P wave rates and different QRS rates. This is dissociation if it is present. Capture beat or fusion beat, if these are present, these are very strong cases for which tachycardia? Ventricular tachycardia. What is a capture beat? During a tachycardia rhythm, ventricular tachycardia rhythm, you find a sinus beat in between. So, or you find a capture beat, fusion beat. What is fusion beat? Sinus beat and ectopic beat, they fuse and they produce a very bizarre type of beat. So if these are present, this is ventricular tachycardia. And if this early part of QRS, that is intrinsicoid deflection, is greater than 40 milliseconds, it favors VT. That's what we discussed, what is intrinsicoid deflection. If you've got an upstroke of QRS complex, which is very broad. So the possibility is this is a ventricular tachycardia. So this is how you can differentiate between ventricular tachycardia and supraventricular tachycardia when you encounter an ECG which is showing broad complex tachycardia. And remember, if you are confused, you can't decide, treat that as ventricular tachycardia. Okay? Presentation of arrhythmias is usually because of patient may present with palpitation, worsening of the heart failure, syncope, chest pain, fatigue. So they all may be presentations of the arrhythmias. And some of the arrhythmias, they present with complaints which are not related to the heart. For example, if there is an atrial fibrillation and patient may form a clot inside the atrium, because in atrial fibrillation, the heart is not, the atria are not contracting, they are just quivering, not contracting. So the blood stays there, a clot forms, and when a sinus rhythm starts, the clot may be propelled, and patient may present with embolization. So you may come with embolic phenomena. So these may be the presentation of patient who've got arrhythmias. Physical examination, you may find weak, fast, slow, or irregular pulse. BP may be low to normal, there may be apprehension and anxiety, patient may be agitated if there is cerebral hypoxia and the cardiac output is low. Some of the patient may present with lethargy, and finally a serious presentation is coma. This is one of the most serious presentation of rhythm disturbances. And when you have got coma, you have to consider the most serious cardiac arrhythmia. What is the most serious cardiac arrhythmia? VF, ventricular fibrillation. Ventricular fibrillation is the most serious presentation of arrhythmias. Labs, you need to have electrolytes, magnesium, calcium, phosphates, because they can produce different type of arrhythmias. One of these is torsade de pointes. What is this? What arrhythmia is this? What arrhythmia category this falls in? It's a ventricular rhythm. And again, this rhythm is quite serious because it also results in failure of heart to produce any cardiac output. And this has to be differentiated from ventricular fibrillation. Now, what is torsade de pointes? What does it mean? Twisting of points across a baseline. So you may have upward and downward complexes, which may look like ventricular fibrillation. Drug and toxicological screens, digoxin, tricyclic antidepressants, amphetamine, methadone, cocaine. You get patients in the emergency with these intoxication. They may have these cardiac arrhythmias. Evaluate for ischemic heart disease. Persistently elevated cardiac enzyme may also indicate ongoing myocarditis. Myocarditis can also present with heart blocks and arrhythmias as well. ECG, Holter recording, EP studies, echocardiography. Now what is this Holter recording? ECG, I presume you know by now. This Holter recording is ambulatory ECG recording. They attach the electrodes to your chest. They are attached with a recording device that continuously records the heart rate and the ECG over a specified period of time, usually 24 hours, and then it is analyzed on a software and tells you what sort of rhythm has been going on. Was there tachycardia, bradycardia, APCs, VPCs, blocks, or whatever it can tell us. Electrophysiological studies are required in some of the patients. For example, patients who got WPW or patients who got abnormal areas firing. You can locate those areas and you can ablate those areas. You can ablate even the track of the WPW. Echocardiography, and you may require sometimes other imaging modalities, or generally not required. They may be required if the patient has dilated heart rate. So why do you need genetic testing? Some of the syndromes of long QT may be congenital, and long QT syndrome is one thing which can predispose you to ventricular rhythm disturbances. Patients can present with ventricular tachycardia, even torsades or ventricular fibrillation, so you need to know that. Myocardial biopsy really required, and we can confidently generally make the diagnosis of myocarditis using different simple techniques like blood test or echo, etc. So we generally don't need myocardial biopsy. It's only needed in few cases. For example, if the patient may have infiltrative disorders, an example of infiltrative disorder, maybe the sarcoid is there, cardiac sarcoid. Otherwise, you don't need this myocardial biopsy. Treatment is airway, circulation, and breathing. What's the problem in this? Yeah? Hasn't this been changed? Is it the same? I've intentionally kept this as used to be the previous case. Now it's circulation, airway, and breathing. To maintain circulation in the basic life support is the most important thing. The circulation is maintained, then you look for airway and breathing. Rapid transport to emergency department if possible. Provide cardioversion, defibrillation in the field, on the move, because if there is hypotension and no cardiac output and it is delayed, there are chances that brain will suffer the most. Vascular access, supplemental oxygen, and monitoring of the patient. Acute ventricular tachycardia, patient may have loss of consciousness and hypotension. Give biphasic cardioversion, 100 to 200 joules. Correct reversible risk factor, withdraw drugs causing long QT, correct electrolyte abnormalities. Lignocaine can be used when the patient has ischemic heart disease, or magnesium sulfate can also be used if the patient has torsades. If the patient has pulseless VT, there is no pulse, what would you do? Give higher strength of shocks, followed by higher doses if it is not reversed. This is unsynchronized. Here you give synchronized shocks. In case if there is monophasic defibrillator, give a 360 joules. IV amiodarone, pulseless VT. Monomorphic VT without structural heart disease are at low risk and do not require ICD. What is ICD? Intracardiac defibrillator. It senses the rhythm and discharges an impulse. So you can use ICD. Class 3 antiarrhythmic drugs. What is this? What is this drug? This is autocorrection. This is sotalol actually. This is not stall, this is autocorrection. I tried to correct it and then it came back again as stall and then I left it. So I'll tell you, this is not any drug. It actually is sotalol. And then you've got other drugs which can be used. Amiodarone, if the patient has LV dysfunction. If there is no LV dysfunction, there is no real advantage of amiodarone. You can use this, ibutylite, etc. Beta receptor blockers, ACE inhibitors, and aldosterone along with statins if the patient has ischemic heart disease and is used in heart failure. Catheter ablation, if there is a possible identification on those EP studies that there are foci or tracts which can be cleared. Idiopathic monomorphic VT in structurally normal heart arising from a focal source that is resistant to drug therapy as well as in those who are intolerant to drug, you can go for catheter ablation. So you see, VT can arise both from automaticity and increased automaticity and because of the circus movements. It can arise both ways. Long-term management. Most patients with hemodynamically unstable VT, they will require ICD. जिनको कार्डियोमायोपैथी होती है, बार-बार उनको fibrillation या ventricular tachycardia होता है, they may benefit from this ICD. Most patients with prior myocardial infarction and hemodynamically stable sustained VT. Most cardiomyopathy patients with unexplained syncope. Most patients with genetic sudden cardiac death syndrome when unexplained syncope is noted. So all these patients are case for the ICD placement. SVT, vagal maneuvers. What are the vagal maneuvers? What they do actually, vagal maneuvers? They cause block at the AV node. They can slow down the SA node as well. So you go for vagal maneuvers, is the carotid massage, Valsalva maneuver, breath holding. If the arrhythmia is not aborted, you can go for IV adenosine or calcium channel blocker. We generally use verapamil. Digoxin can also be used, but digoxin takes longer time in causing the AV block. If there is wide complex tachycardia, decide this is ventricular tachycardia or this is supraventricular tachycardia. If the patient is unstable, treat as VT. Go for electrical cardioversion. Procainamide, propafenone, flecainide can be used in normal heart. Otherwise, amiodarone can be used in patients who've got heart failure. Atrial fibrillation and flutter. Rate control with calcium channel blocker, digoxin, amiodarone, or beta blockers. What is meant by rate control? If the patient has faster ventricular response with atrial fibrillation, if the patient has faster ventricular response, the heart rate is fast, you can slow it down. What's the advantage of slowing it down? What happens when you slow down the heart? So there is increased filling time. It's always diastole which is affected. Systole remains the same. So diastole becomes larger. So there is more ventricular filling, there is more ventricular ejection. So the cardiac output improves, and the second thing is there is improvement in the coronary fillings because the coronary filling is during diastole. So myocardial perfusion becomes better. So the objective is that you reduce the heart rate. And then you can get the sinus rhythm with DC cardioversion, or drugs like flecainide, ibutylite, or propafenone can be used to achieve the sinus rhythm. Now when you go for achieving the sinus rhythm, what is the precaution you have to take? I just told you. If the patient has atrial fibrillation, there will be possibility of clotting of blood in the atrium, and you convert into the sinus rhythm, the atria contracts synchronously and pushes the clot, and you can have embolic phenomena. So you have to actually anticoagulate the patient and plan cardioversion. You do an echo, you find there is no clot, you can go for a cardioversion. And if you on echo you find a clot, you just stabilize the patient on anticoagulants and then go for a cardioversion. Long-term calcium channel blockers, beta blockers, and digoxin. Radiofrequency ablation in symptomatic patients. Failure of medical treatment, and WPW. You can go for an RFA, that is radiofrequency ablation. You burn that abnormal area. In case of confusion, all broad complex tachycardia should be treated as ventricular tachycardia. Now, what will you do if a patient has ventricular fibrillation, you give DC shock of maximum intensity. Correct the correctable factors if possible.